Hi, Assalamualaikum. My name is Noraishah binti Omar Othman. Today I'm going to present my case study presentation, acute low back pain. Okay, low back pain become a widespread health problems and giving impact to functional disability, work productivity, and increase in healthcare expenditure and cost. Approximately more than 50% of workers in Malaysia has been reported low back pain related to poor posture, work environments, and other physical factors. As a strategist, okay, multidisciplinary approach has important roles for better improvement on long-term pain and disability, including combination of physical, psychological, economic educations, and work-related component. Okay, as a physiotherapy plus ergonomic training will give a greater improvement in pain and functional performance among patients with low back. As we know, low back pain and motor control is important and really related. Okay, uh, core muscle control will be affected by lumbar multifidus, transverse abdominis, and pelvic floor muscle, and then its work considered as integrated treatment program. This is discussed by Hodge in 1997, and in 1999, he found that patients with chronic non-specific low back pain will show disturbance in morphology and functionality. So it proved by Rousseau, his findings, motor control exercise was superior to spinal manual therapy and also superior compared to general exercise, which is regard to pain and disability during all time periods. So in retaining a normal motor control pattern, educate relaxation is an important first step in inhibit tone of the global muscles, thereby allowing a more isolated contractions of the core muscles. So four of my cases is Mr. S, male, 32 years old, Malay, and referred for low back pain, and doctor management is conservative for physio management. Main complaint from this patient is pain over mid-back in prolonged sitting and standing, especially in working hours, and the pain continuously at night, sometimes uh, at night radiating to the left buttock and plus with numbness. Okay, so currently patient had increase in pain for 1 week plus, unable to strengthen lower back and had a limitation of movement during prayer. He had admitted to our daycare for MRI investigation and medication under supervision on the 3rd December 2020 and referred for outpatient physiotherapy after discharge of 1 week. So this patient had history of MVA on 2019, sustained left ACL torn, and was under non-surgical management of physiotherapy for 3 months. And for medications, what doctor give is a Celebrex for pain relief and also Neurontin as a muscle relaxant. And I found out this patient is a Maybank staff and working at kiosk in Amanjaya malls. So he has difficulty in computer setting in workplace, and he has been changed a lot of posture using PC or laptop in the kiosk environments. However, the pain is still there. So, from the pain assessment, he complained of dull, aching pains constantly at mid-back, mid-thoracolumbar back, okay, and numbness at the left side buttocks, okay. It was during bending, sitting, standing, and as the day progressed until night. Okay, so as a relieving factor is rising, lying, and during movement. So he need to change a lot in posture. For MRI results, okay, the impression was a normal appearance, no disc protrusion, diffuse bulge or nerve root impingement. Okay, so we can see a normal result of MRI. Okay, and then for posture assessment, okay, I assess two posture in sitting and in standing, because this is the two movement that he do a lot during working hours. So in sitting, there is increase in kyphosis, and in standing also increase in kyphosis. So lumbar lordosis has been reduced in reduced in sitting posture and increasing during standing posture. I also find out that this patient has a bilateral flat foot. For movement loss, this patient is having moderate loss of flexion and extension movements, and also minimal loss of rotations and side flexion in both sides. And other joint that I observe is thoracic and pelvic movements. For thoracic, limitation in extension, and for pelvic, reduce its anterior pelvic tilt movement. So there is no abnormality detected for motor deficits, and all sensation are intact. I've done passive accessory intervertebral movements. So for L1 until L5 S1s, there is a grade 3, grade 4 stiffness for L4, L5, and uh, springing ankle and hypermobile. So that means there is slightly tight in between those joints. Muscle strength, I observe right side is a 4/5, left side is 3/5 for those muscles. And I've done a few muscle length tests for the hip flexor, iliopsoas, piriformis, erector spinae, and also hamstring. So I found out for the left side muscles, there is a restricted with springy ankles, and for the right side, there is restricted for erector spinae and also hamstrings. So I do motor control screening, okay, which is trunk flexion, okay, hip flexion in standing. So I observe SI joint, and anterior and pelvic tilt in standing. Also, slump positions. I observed lumbar lordosis. So we found out that hamstring and gastrocnemius a little bit tight. Okay, and these patients unable to maintain lumbar lordosis during movement. Another movement I observe for motor control is in quadruped positions, which is I ask patient to move hip and shoulder forward and backwards while maintaining lumbar lordosis. However, he cannot do. Also in prone lying, uh, this patient have a slightly uh, pelvic rotations during knee bend. Okay, that indicate that this patient having weak core muscle control and also thoracolumbar tightness. So my problem listing: pain over mid lumbar, left lateral paravertebral muscles, and left piriformis. It limits in movement of flexion and extensions, and that's why this patient is having difficulty in performing prayers. Limited ROM over trunk and reduced pelvic mobility. That's why difficulty to prolong standing and standing, and patient unable to continue work without pain for the whole day. Reduce core muscle control in movement, which is unable to maintain good posture in sitting and standing. And in ADLs, it limits movement in office and also house after work. Another problem that I found out is these patients having lack of awareness and education on good posture. So for clinical reasoning, okay, all those pain limited range of motion, and reduced core muscle control. Okay, this is associated with muscle tightness over iliopsoas, left piriformis, hamstring and gastrocnemius. Okay, and full core control over thoracolumbar muscles and pelvic, and also lack of awareness and education on posture. So my short-term goals is to reduce pain in 2 weeks, to improve muscle flexibility and core control for 3 weeks, to improve functional movement in ADLs 3 weeks, and to improve patients' awareness and education. For my long-term goal is to make patient return to ADLs with optimal functions without disability for more than 1 month. As an intervention, I teach patients a few motor control exercise, which is static abdominal exercise, the basic ones. Okay, and then I progress it to few steps like footwork, okay, hip flexion in supine and SLR in supine. Okay, I do bridging, knee extension in sitting, quadruped, and a progression of quadruped, sitting trunk flexions with progressions, sitting hip and knee flexions, okay, and standing half squat while maintaining lumbar thoracic with weight resistance. So I show you the picture later. And after motor control training, I will do pain relief for hip pain and tense, back stretching exercise, which is for home exercise program, patient education. So I review this patient correct posture in sitting and standing, and I give ergonomic task modification in office, in the techniques how to adjust the table and chair, hand, foot, and buttocks positions. Okay, and how they differentiate to use PC and also laptop. For home exercise program, pamphlets of stretching exercise were given, and pamphlet of posture ergonomic also were given. This is exercise that I say. Okay, so I evaluate every movement, and this also considered as my review, evaluation, intervention, and evaluation. So bridging, I will ask the patient to contract the abdominals and lift up the buttock up and down. Okay, try to control the contraction without losing it, and to maintain lumbar lordosis. Then I progress into bridging with straight leg raise, single bridge, okay, with same contraction of transverse abdominis and multifidus. Okay, next is prone knee bend. I ask patient try not to move lower back during knee flexions, and there's this slightly movement there. Another one is quadruped positions. Okay, so this patient will ask to maintain lumbar lordosis, good trunk control, okay, and contract abdominals while moving forward and backwards. Another exercise I do is in sitting and standing. So in sitting, the first one is slump exercise, which is I ask patient to sit and lift up one leg up while maintaining lower back, and I progress it to uh, trunk flexion and a little bit movement of the upper limbs with resistance. Next, I ask patient to do in standing trunk flexion, okay, and then I progress it, okay, while flex the body, okay, do upper limb exercise without losing contraction of the abdominal and maintaining lumbar lordosis. Then I progress it to half squat. Okay, ask the patient to contract the abdominal, try to maintain lumbar lordosis and cervical. Okay, ask the patient to do half squat few times. Next, for hip flexions, I ask patient to do it against the wall to block the movement from the pelvic itself. And another one is side flexion of the trunk, also against the wall. So as a review, okay, I will assess these patients in next sessions for pain, range of motion, and core muscle control, and to review motor control exercise program, and to review posture. As a discussion question, okay, so I found out this patient is having a normal investigation, clinical investigation, which is when he come to me, there is a lot of complaint of pain, okay, but there is no problem with the spine, okay. So I do a lot of motor control exercise, and actually it's working. So, and patient also claim that the pain is reducing after the exercise. This is my reference. So that's all from me. Thank you very much.